to start our table for, wait. Yeah.
The screen one. The
Yes,
screen.
I'll start
written,
sharing
yeah.
the screen.
The next question.
Yes, yes.
Okay.
Okay. Ready?
Yes, ma'am.
Next slide. So this is on airway, again, minute ventilation, mechanical ventilation and ABG. So identify the set indications and contraindications. Remember time, 15 minutes again we are targeting.
Yes. Is a percutaneous tracheostomy set, ma'am.
Anything specific, percutaneous tracheostomy or something else you want to add?
Is a serial dilution technique.
Is it serial dilatation technique, serial dilators you can see here?
No, single dilator technique.
Then?
Seldinger technique.
Where we are using single dilatation technique. In percutaneous tracheostomy, what you are using usually? What is?
There are various techniques are there, madam.
But this Seldinger technique, with this
yes.
dilatation, we are using serial dilator, right?
Yes.
But here there is no serial dilator. Only one dilator is there, no?
Yes, ma'am.
So what it is? What it could be? Okay, you can see one blade, needle, one guide wire, one dilator, and tracheostomy tube.
Yes, ma'am. Dilator catheter.
Okay, indications and contraindications.
In weaning difficulty patients, in chronically
Okay, that is the percutaneous tracheostomy indications they are going to say now. But this is exactly, you are not exactly identifying the structure. What else? 5 seconds, you can apply your mind and say.
Trichothyroid, that I said.
Pardon? Yeah.
Trichothyroid, that was.
Yes. So it is needle.
Trichothyroid.
Yes. So now you can say indications and contraindications.
Yes, difficult in difficult airway conditions. Then supraglottic airway devices also we can't use. Then we can use this.
Yes. Okay. Can you name one contraindication related to that?
Any tumors related to larynx?
Yes. And if you're suspecting any laryngeal fractures or any anatomical disruption, then definitely it's not a good idea, no? Because you can cause grave situations.
Yes.
Okay, next. So identify the problem.
Ventilator scalars.
Can you tell me what is the setting? What is the mode?
Pressure control mode.
Okay. And what is the problem here? It's clearly highlighted also, no?
Is the trigger?
Pardon?
Double triggering?
Yes. Are you in doubt about it? Asking or telling me the answer? So be sure, double trigger, right?
Yes,
How you are going to correct double trigger?
We have to decrease the sensitivity. trigger sensitivity.
Decrease the trigger sensitivity. But what is the pathophysiology or physiology behind double trigger? Tell me that. Okay.
Oh.
We will discuss that in the answer sheet. Next. Now, identify the problem and how to troubleshoot.
Is a air leak problem.
Okay. So, just tell what is this volume, pressure loop, and flow time loop.
In flow time
Flow
loop,
volume.
it touches the x-axis, madam. It's not. So it's air leak.
Okay. And how to troubleshoot?
We have to see the circuit, any leakage is there. Check the circuit.
What else? Only circuit? You can find leak only there.
No, madam. BPF, any bronchopleural fistula.
Okay, good.
Patient
What else?
related.
What else? So just always answer in a systematic way. From ventilator till patient, you will check the circuit. Okay.
Yes.
Then tube also. Tube also might dislodge, not completely extubated, but if it is getting dislodged or there is any cuff leak, then also it can cause this, right?
Yes,
And
yes,
suprapleural fistula, rightly said. Okay, next. Now identify the issue and troubleshoot.
It's dynamic auto pip, man. It's not touches the baseline. Expiratory limb doesn't touch the baseline.
But it is looking like it is slide almost towards the end. It is touching.
Oh, yes, it's touching it.
Yeah. But what is the issue here?
Peak pressures are high, madam. 50 is there.
Yes. Yes.
But P flat is normal only. So any airway obstruction complaint is normal, madam. But any airway resistance or
What else? Airway resistance, that's fine. So what you will check for, how you are going to troubleshoot?
we have to check for any block in the ET tube or any block in the circuit.
What else? So you're right that P flat is normal. So, but anyway, you have to rule out the pneumothorax part also, because that can also increase your airway pressures.
Yes.
Obstructions, blocked tubes that are there. Then if patient is having spasm, but spasm will cause autopeep.
Yes.
Okay, next. So just identify the mode of ventilation here.
PRVC.
Look at it carefully.
CPAP releasing spontaneous breaths.
What can you see on the right side? What is there on the right side? The graph which are labeled.
Spontaneous breaths, CPAP released to airway,
Huh?
airway release, airway pressure release ventilation.
Yes.
APRV
Good.
most.
Yes. Next. Read the question.
A 60-year-old woman is ventilated for pneumonia with SIMV rate of 12 breaths per minute of tidal volume 700 ml with PEEP of 5 centimeters of H2O. The pressure limit is set 35 centimeters. Your resident calls you at 1:30 because she is sweating and fighting the ventilator, and high pressure alarm keeps going on. An extract from her chart is shown in the below. Discuss the findings. Heart rate 12:30, 90, and 1 o'clock 1:30 it's keep on increasing. 140 fine, 149. Systolic BP 120 baseline and it's decreasing 80. Respiratory rate is increasing and peak inspiratory pressure is increasing. And exhale tidal volumes 700 later decreased to 300. FiO2 requirement is increasing. PaO2 requirement initially PaO2 is initially 100 and it is decreasing 50, 54, and PaCO2 is keeps on increasing. So it's both ventilation and oxygenation failure, madam.
Yeah.
Because
So what are the possible causes? What can lead to this?
peak inspiratory pressure is increasing, so we have to rule out the pneumothorax condition.
So, can you tell me why this exhale tidal volume? Any comment on this exhale tidal volume? Why it has decreased? The set tidal volume patient is on SIMV mode.
Yes.
Tidal volume 700 ml.
Yes.
And patient was having quite good exhale tidal volume. So why it is on the lower side now?
Any obstruction causing the exhale tidal expiratory flow limitation may be there.
Okay. What else?
So autopip may be present.
Okay. Autopy. So again, what are the possible causes?
It's primary disease. ARDS may be worsened, madam, because of pneumonia. ARDS happen. It may worsen.
But you tell me now, 1 o'clock it was not exactly okay, but tidal volume and all was okay. FiO2 was 40%, PO2 was 80, but 130 this became so rapidly became so bad.
Yes. So any obstructive
and how you are going to manage it? Because this is very common phenomena seen in the ICU.
Yes,
and again, I didn't get exactly why the exhale tidal volume is so low now.
Hypertension is there and peak inspiratory pressure is increasing. FiO2 requirement all are increasing. So could be possibility of pneumothorax, madam.
Yes, very good.
So we have to see focus and we have to check for lung sliding sign.
Okay.
If pneumothorax is present, we have.
If pneumothorax is not there, then what else? So you always have that possible causes, na? So
Yes,
you have to keep open your options that all these differentials can be the possibility. If no pneumothorax doesn't mean that there is no issue, right?
Yes, ma'am.
So
Any
another
obstruction?
one you told me, autopy, any obstruction, right?
Yes. Any tube block?
Okay. Correct.
Tube block.
Fine.
Because of any mucus plug, tube may be blocked. We have to see.
Or if patient is too much fighting with the ventilator, that also can hamper the ventilation.
Too much biting.
So, maybe ignored for half an hour and she was biting the tube. That can also cause this.
Yes.
Okay. Next.
An elderly patient has been admitted with vomiting. He has history of cardiac failure for which he takes diuretics and has had past peptic ulcer. He becomes unresponsive on the ward. The following gases are obtained. Surgical resident thinks the patient has CO2 narcosis. pH 7.59, PaO2 34, PaCO2 51, bicarb is 46, base excess is 25. So describe what are the likely causes. He has history of vomiting, madam. So and he's taking diuretics also. And ABG is showing the alkalosis picture, metabolic alkalosis.
Yes.
Mostly because of his vomiting.
So metabolic alkalosis is because of the vomiting only.
And also he's taking diuretic in.
Yes.
Contraction alkalosis, madam.
Correct. So what do you think? What is the cause of his collapse?
It becomes unresponsive on the mouth. Okay.
So what could be the cause of his collapse? What problem metabolic alkalosis will cause?
Alkalosis, hyperventilation.
Hyperventilation with metabolic alkalosis?
Nothing. No.
Okay. So do you think that again, so CO2 narcosis is the right cause for the
No, madam.
collapse?
It's the 51 only. It can't.
Yeah. So then, because you have to think according, you were called
Yes.
that this has happened. Then you have to think what could be the cause for the collapse. Think and act. So what problem metabolic alkalosis will have on heart? Any problem?
Acidosis, maybe cardiac contractility will decrease. But alkalosis, yes.
What happened to the electrolytes?
Electrolytes, hypokalemia may be present, madam. And
So
hypocalcemia may be present.
What it will cause?
Arrhythmias, hypokalemia causing arrhythmias and arrhythmias leading to
Can
unresponsiveness.
arrhythmia cause unresponsiveness?
Yes, ma'am.
Second is, what about his PO2?
PaO2 34. Hypoxia also one of the
Correct.
cause
So
hypoxia.
exactly. Okay.
Yes, ma'am.
Okay. Next.
A 28-year-old woman presented to the emergency with rapidly progressive weakness of all four limbs and associated myalgias. She denied sensory symptoms and there was no sign of loss of executive function. She had no prodromal symptoms. The following results are obtained. pH 7.23, PaCO2 29, bicarb 12, base excess -14, and potassium is low, 0.9. So she had acidosis, metabolic acidosis with hypokalemia, madam. Metabolic acidosis with hypokalemia. Mostly, and pH urinary results are pH 7.5 and so potassium is 37 and chlorine is 22. doses, madam?
So first, tell me what you like. We are along that. What should say?
Normal. Here, 1 1 lower gap.
Normal and the negative ion. What all is given, that is only the negative ion. Chloride is a negative ion.
So positive anion gap is there, madam.
Yes, and what do you expect normally?
Positive anion, negative anion
If there
gap.
is metabolic acidosis,
Recording in
if
progress.
there is diarrhea,
Yes,
if extrarenal, then kidney will try to
save the
excrete negative ion with ammonia, right?
yes, ma'am.
So then your chloride will be high.
Okay.
Your urine anion gap will be 0.
Yes, ma'am.
In case of renal tubular acidosis, this
Okay.
it is not getting excreted. NH4Cl is not getting excreted.
Okay.
That's why it's causing renal tubular acidosis.
Okay.
So then your urine anion gap will be positive.
Yes, ma'am. Positive anion gap, relative blood acidosis. Negative or 0 diarrhea.
0, yes, extrarenal.
Yes.
Okay.
Yes,
So
ma'am. Yes, ma'am.
you rightly, it is renal tubular acidosis. What kind of what type of renal tubular acidosis it could be?
It's type 1, madam. Hypokalemia is there. And type 1 or type 2, both are hypokalemia.
Very good.
So here,
think exactly. In fact, I also won't be able to say, but that what it will be exactly. But type 1 or type 2. Okay.
type 1 is, yes, ma'am.
Yeah. Next. Good for this. Okay, let's end it.
Yes.
Okay, come with the answers.
Just give us a minute, huh?
Yes, yes.
Yes.
So, yeah, next slide.
Next. Come on, next.
Huh.
Yeah.
So this is needle cricothyrotomy set, because you saw there's a puncture needle, guide wire, and a single dilator and a tracheostomy tube. Otherwise, normally what we get is serial dilator, right?
Yes, ma'am.
So that's why it is not your percutaneous tracheostomy set. This is the needle cricothyrotomy set. Again, indications you mentioned for difficult airway in cannot intubate, cannot ventilate conditions, and your very important contraindications will be if there is anatomical disruption. So then in that condition, and if you know that patient is severely coagulopathic, then also it might be difficult. Next. So yeah, this is double trigger, right? This you couldn't answer, right, Dr. Pratap?
Yes, ma'am.
So this is double trigger. So double trigger is when you are seeing 2 breathing efforts in one cycle. Okay. Why this happens? If suppose your neurological part is still in the inspiratory phase, but the ventilator cycle that you have set is going into cycling phase, right? So in that condition, ventilator is trying to cycle, but neurologically, the patient wants to take breath.
Yes.
When the patient is not severely, deeply sedated, patient is allowed to make attempts. So in that condition, patient is still in the inspiratory phase, but ventilator is trying to cycle from inspiratory to expiratory. So in that
Yes.
condition, you will see that. Okay.
Yes.
So
Yes.
now I told you patient is in inspiratory phase neurologically. So how you are going to correct it in your ventilator setting? Patient needs longer inspiratory time. And how you can achieve longer inspiratory time? Tell me.
Increasing respiratory rate, we have to respiratory rate.
What you will do with the respiratory rate? What change you
I
will
ratio
do
we
with
have
the
to
respiratory?
I ratio we have to increase, madam.
Matlab, if you are increasing I ratio, usually it is we are saying it in terms of expiratory time. So you mean to say you have to increase the expiratory time?
No, ma'am.
Then
Increase the inspiratory time.
yes. What else? RR कम कर सकते हैं.
Yes.
What else? This is a very common ventilator dysynchrony you will see in
We can increase
patients.
sedation, madam.
We can increase the sedation. Other than that, suppose if you are trying to wean off the patient, then
Yes.
you have to appropriately set your ventilator. Na?
Yes,
Suppose patient needs a respiratory rate of 12 to 14, suppose patient is having alkalosis, metabolic alkalosis side. So definitely
Okay.
patient will try to compensate it with the low respiratory rate, or 12 to
Yes.
14, maybe normal respiratory rate also. 14 also you can accept if CO2 is not causing the problem. Then and you are setting the ventilator with 22 ka rate or 20 ka rate. That patient doesn't need that. So it's not needed. Unnecessary patient will have double trigger, and you will think that decreasing the I ratio also, it's not getting settled, and you will increase the sedation. Again, your weaning will be the problem. So
Yes.
then just see, come down with the RR. See at what RR, if this is a situation, I am guaranteed telling you that your double trigger will get settled if you are giving more inspiratory time by decreasing the RR. All the time, your I ratio, decreasing I ratio is not possible, because at one point of time you might see there is auto peak because your expiratory time is so low.
Yes.
So in that condition, come down with the RR if it is feasible, or
Yes.
else try see if you can come down with the tidal volume also a little bit.
Yes.
Okay.
Yes, ma'am.
So sedation will be the last resort.
Yes.
So double trigger, decrease RR, increase inspiratory time, decrease tidal volume if allowed. If nothing is working out, sedate and paralyze.
Yes.
1 second, I am joining with my laptop. I think this time it's working.
Do let us know, Dr. Ritika, when we should stop sharing.
Okay. You stop sharing.
Yeah, okay.
I
So
hope
no, stop sharing.
won't be any problem this time. We are in the answer sheet, no?
Yeah, the debrief.
Yeah. My screen is visible?
Not yet, but it will be, yeah.
Is it?
Full screen.
Okay. That time only this went black when I put
Oh,
slide mode. I
yeah.
hope it will work this time. Ah,
Shumu, this was on which, what is the number?
No, I'll search
You
that.
remember that. Okay.
Yeah. Okay.
Yeah. If you can just do full screen, that will be good.
Okay. Thank God.
Thank you. Thank you so much.
Thank you. Okay.
Okay.
So now identify the issue and troubleshoot. So You rightly identified. So it's seeing the scalars, you can say this is volume control mode of ventilation, right?
Yes, ma'am.
And okay, we don't know the settings, so ventilation volumes we can see, and peak pressure is 50, P
50.
flat is 17. So peak pressure definitely is going on the higher side. You rightly said obstruction, one of the cause. So we have to see from ventilator end till patient end, identify the obstruction. Okay?
Yes.
So in the circuits, filter very commonly missed, because at times we are giving nebulization by mistake. If sister is attaching the nebulizer at a wrong side, that is proximal to the filter, that can block the filter, HME filter. So filters definitely you need to check. Then any tube blockade, any secretions, any blood clot that is blocking the tube, that can also cause obstruction and high peak pressure. Pneumothorax, spontaneous pneumothorax can happen. So that can also cause high peak pressure. And definitely, if suppose patient is intubated for lung issue, then definitely you can think of worsening lung parenchyma. Okay. And
Yep.
don't forget about this abdomen also. If there is, you suspect that patient is having this any abdominal issue, don't forget to examine abdomen also, because IAP can also increase your peak pressure. Okay?
Yes.
Mode. Where is the second image here? Okay, anyway, you identified it correctly. This is APRV,
APRV.
airway pressure release mode, because in this is a weaning mode, right? So in this,
Yes.
patient is getting ventilated at two pressures. One is high pressure, one is low pressures.
Low pressure.
So this is for oxygenation, and second one is for CO2 removal. Okay, so again, this is not available in all the ventilator, but the advanced newer ventilators, this APRV mode is available. So you must read APRV mode, NAVA, and a few new modes which has come now for exam purpose. They might not ask you in the Viva in the case, but they can give you in the tables. So this one, SIMV rate 12, tidal volume was 700, PEEP of 7. So now pressure limit was set at 35 centimeter. Okay. So now what I wanted to ask you are seeing this 300 exhale tidal volume. It means your tidal volume is decreasing. Why tidal volume is decreasing? Because your set pressure is 35. So now, because of the causes that you mentioned, obstruction, pneumothorax, or fighting with the ventilator, what this all will cause? This will increase your peak pressure. So it's SIMV mode, right? If your peak pressure is reaching till 35, what will happen? This is a protective mode, protective part. Na? This is your alarm limits, right? So what will happen? Ventilator will stop, decrease the tidal volume, so that your peak pressure is not going above 35, right? And with the current pathology, 300 tidal volume is generating equal 35 ka pressure, peak pressure. That's how ventilator calculate, na? And that's how these alarm limits work, right?
Yes. Yes.
So that's why your exhale tidal volume decreased. Got it?
Yes, ma'am.
So now this and simultaneously, because of the underlying problem which happened, patient is having tachycardia, she's having a drop in the blood pressure, hypotension also. In fact, RR is decreased because now it was 24 here, it is decreasing because patient is having hypotension and going towards decreased RR also because of the poor GCS now. Okay. And
Yes.
inspiratory pressure is reaching the limit, 35. It was 24 here. It's 30. It's 35. So you have to specifically mention this part. Okay.
Yes.
Because peak inspiratory pressure is reaching the alarm set limit. So that's why tidal volume is 300, because its alarm is not allowing to deliver more tidal volume. Okay. Then
Yes.
because CO2 is increasing here. Okay. FiO2 40, 40, now 60. So definitely there is some issue with the parenchyma. That's why your FiO2 is increasing, or your FiO2 is increasing because your PCO2 is increasing. because minute ventilation कम हो गया ना, exhale tidal volume is low, so your minute ventilation is low, so your CO2 is increasing, and now you know by alveolar gas equation your CO2 will build up, your PO2 will automatically come down, right?
Yes.
So that is the whole pathology here. So possible causes, you mentioned it. There could be some ventilator fault we can first think of, but obviously if everything is checked, it's a good quality ventilator. Unlikely, but definitely not that it cannot happen. Obstructed tubing or endotracheal tube, right bronchial intubation, all things which can increase your peak pressure. Bronchoconstrictions happen, patient acute change in the lung compliance, like patient had a pulmonary edema, or there is pneumothorax, or there is autopnea, right?
Yes.
Again, if the patient is fighting with the ventilator, then also this can happen,
Yes.
but that will be very obvious. So you have to check systematically.
Yes.
And the clinical examination and act accordingly.
Okay.
Now, this elderly patient, vomiting, cardiac failure history is there. So he is on diuretics. Peptic ulcer, why I mentioned? Because patient can be on alkali containing syrups are there. Na? So patient can be taking that also. So severely alkalotic. And there is marked metabolic alkalosis. So CO2 may be trying to compensate, or we don't know that patient is having any acute patient is a COPD patient or not. So we don't know that, but obviously this bicarb is contributing to metabolic alkalosis. Okay.
Yes.
PO2 is very low. So hypoxia is there. Now, with this PuCO2, you were right that it will not cause CO2 narcosis. So here, the cause for his collapse, alkalosis, hypokalemia, leading to arrhythmias or hypoxia also. Patient is, because cardiac failure history is there, again, went into pulmonary edema, hypoxic and collapsed. That also could be the possibility. So respiratory compensation, severely hypoxic. This again already discussed. Hypercapnia will not explain unresponsiveness. So it could be because of the hypoxia, or IC bleed, hypoglycemia. So your first line which you will rule out hypoglycemia wherever we are going for any such kind of fall in the ward. The first thing what we ask for is, what is the blood pressure? We check the blood pressure, we check the pulse, we check the how is the pulse. In fact, pulse is present, how is the pulse, and how is the sugar, right?
Yes.
So hypoglycemia, and obviously IC bleed also you don't can't rule out, because you have to keep this in mind, because this repeated cardiac failure patients, if low output states, so they are already on antiplatelets and anticoagulants.
Yes.
So keep that also in mind.
Yes.
So hypoxia may be related to impaired respiratory drive caused by severe alkalosis, but other causes could be like aspiration, pneumonia, severe cardiac failure, pulmonary embolism. And severe alkalosis is likely to be related to loss of acid in vomit, NG tube, volume contractions, alkali therapy for peptic ulcers. Metabolic alkalosis may be compensating for, I told you, chronic respiratory acidosis, which is unveiled when the later is rapidly reversed. Like agar patient is tachypnic agar hote hai, so CO2 will immediately come down, but bicarb takes time. So in that condition, the compensating part for the chronic respiratory acidosis will get reversed, because CO2 will immediately get washed out with the tachypnea. CO2 will immediately get washed out of the lung. But bicarb takes time, 12 to 24 hours. Kidney takes time. So in that condition, patient can present with metabolic alkalosis. You got my point?
Yes, ma'am.
So 28-year-old woman, weakness in all four limbs, myalgia, there is sensory symptoms, no sign of loss of executive functions, no prodromal symptoms. Now, you rightly diagnose this case. But I wanted ki how you are going to interpret. Okay? Matlab, aisa, I know ki it's a very quick thing, metabolic acidosis, hypokalemia, this is renal tubular acidosis. But your marks will be divided on metabolic acidosis, normal anion gap metabolic acidosis with hypokalemia, with this your urinary pH and
Yes.
urinary anion gap. Okay.
Yes.
So again, I'm reading it. You only read it, what it is. You will understand.
Yes. There is a compensated non-ion gap metabolic acidosis associated with marked hypokalemia and mild creatinine CK rise.
Yes.
Urine testing indicates proteinuria and inappropriately high urinary pH for degree of acidosis and positive urinary anion gap. These results are keeping with type 1 and type 2 renal tubular acidosis. The proteinuria suggests a renal cause. The weakness is related to the severe hypokalemia and should resolve on correction of the potassium level. The urinary anion gap can assist in determining if the cause of non-ion gap metabolic acidosis is renal or extrarenal. Ammonia is the chief mechanism of renal excretion of acid. To aid excretion, it is coupled with chloride. Consequently, in renal compensation for extrarenal causes, the chloride level is high. Thus, urinary anion gap less than 0. In renal causes, the urinary anion gap is positive.
You got it? Because
Yes.
your ammonia will bind with H positive. It will make NH4 positive. NH4
Yes.
positive will combine with chloride. It will make NH4Cl and that will come out in the urine.
Yes,
Okay?
ma'am.
So,
Yes.
agar metabolic acidosis is because of the extrarenal GI cause, then
Yes.
kidney will definitely try to make up with that metabolic acidosis. So what kidney will be do? More excretion of H positive. But
Yes.
H positive कैसे आएगा? NH4Cl बन के आएगा ना
Yes, ma'am.
in the urine. So urine chloride will be on the lower side.
Yes.
So it will be urine anion gap will be 0.
Yes, ma'am.
But in case of your renal tubular acidosis, because it's not chloride is H positive is not getting cleared from the renal tubule. So chloride is also not coming out. So chloride will be little on the higher side.
Okay.
Sorry, urine chloride will be on the lower side. So urine anion gap will be positive.
Yes.
If you will get to know about this mechanism now, you will never confuse.
Yes.
If you will try to remember the value, you will always get confused.
Yes.
Okay?
Yes, ma'am.
Okay. Next, who is going good? It was good this time.
Thank you.
Next, I think Dr. Sudeshna suggested.
Yeah. Dr. Sudeshna, are you
Sudeshna, are you
there?
there?
Yes, ma'am, I'm there.
In the meantime, can we talk about the next volunteer? Can we ask? Anybody would like to come up? Dr. Ashwini is there. Okay, great.
Okay. I don't know what is going on with my.
You want us to, what has happened is you have maximized the
No,
screen.
in my screen now, weird things are coming.
Okay. Okay, let me just check. Shoma, are you there? Screen wala karna hai.
Okay.
हाँ.
Is it visible?
No, we are sharing now.
Acha, you are sharing?
Yeah.
ठीक है. So Dr. Sudeshna is there, no?
Yes, ma'am.
Okay. 1 second. I'll start the timer again. Let's start. Next slide. Read it.
Cystic fibrosis patient presented with severe respiratory failure. Comment on the chest X-ray below. What organism may be responsible for this chest X-ray appearance in this group of patients, and what is the antibiotic of choice? This is a PA view of a chest X-ray given, which is showing infiltrates in both of the lung windows of both sides, and likely it's a case of pneumonia, and or it may be also progressing to ARDS as well.
Good.
And organisms responsible includes the enterobacters, as well as the atypical organisms like Morganella and all. And if coming from the community, then it can also be Staphylococcus aureus or Streptococcus as well.
Yes.
For them, the antibiotic of choice coming from
No,
the community.
one important pathogen you are missing for cystic
H-influenza.
fibrosis.
Haemophilus influenzae.
Yeah. H influenza. One more.
Yes.
You answered most of them. One more. Pseudomonas. Okay.
Pseudomonas. Yes, yes, yes.
But very important,
antibiotic
definitely
of
Staphylococcus
yes.
aureus.
Yes, yes.
Hmm.
Antibiotic of choice, if it's coming from home or the community based, then first will be BLBI kind of antibiotics or third degree cephalosporin, along with any macrolides or doxycycline. And if I'm concerning with Staphylococcus aureus, then maybe I will start with piperacillin tazobactam and macrolides as well. And for hospital-based infection, we need to start with carbapenems, if suspecting hospital-based carbapenems, monobacterums, etc.
Yeah, but you said Staph aureus could also be the possibility. So do you think BLBLI, piperacillin tazobactam, is a good choice for that?
No.
Then you have to start with some empirical antibiotic, no? And
Yes.
you told me what all could be the possibilities.
It's like any ampicillin group.
Okay. Clindamycin also you can suggest, no?
Gentamicin.
But if suppose you are suspecting MRSA because of the repeated hospitalization, then MRSA antibiotic with MRSA cover with definitely anti-pseudomonal cover also you have to give.
Anti-pseudomonal BLBI has a strong anti-pseudomonal coverage.
Yes. But don't forget about the MSSA and MRSA, right?
Yes.
So
With
one question I want to ask.
yes.
One question I want to ask in this is additional. Actually, I should have kept one slide for that. So suppose you are getting one, just listen carefully. You are getting one, this patient's BAL was done and you got the culture report, sensitivity report. And sensitivity, it is showing cefoxitin sensitive and it is clindamycin sensitive. This is erythromycin, inducible erythromycin resistance is there. Okay. And other MRSA cover, जितने भी है, vancomycin, teicoplanin, this is sensitive to all that. So then what is this test, inducible clindamycin sensitive, erythromycin resistant. So what next you will do? Are you going to give clindamycin to this patient?
It's not very sure. I read somewhere of inducible resistance, but I can't memorize at this moment something.
Okay. So there is something called D test, right? Have you heard about it?
Yeah. No.
Okay, we will discuss this in the answer set. Okay. Next.
We are old female, but there. Swelling, legs, by heart rate 140, respiratory rate 34 minutes. Face by document ratio is cardiac. The in along the hilum. So this can be a case of suspected volume overload in the background of heart failure, and also evidence of pleural effusion secondary to any LRTI as
In
well.
the background of heart failure, you said?
Yes.
Means background of heart failure, or this is heart failure?
No, this is heart failure. This
Yes.
is heart failure, but it may be pericardium cardiomyopathy as well,
Yeah,
because the
perfect.
patient being pregnant.
Perfect. Yes.
Pregnant.
So,
So other investigations, I would obviously like to have one echo, 2D echo with color Dopplers as well as the next common, as well as an ABG to rule out the pulmonary and cardiac causes.
okay. Any other basic investigation that you are missing?
ECG.
Yes.
ECG, ABG, echo. Next investigations I will have to do.
और एक हम usually लिख ही देते हैं इसके साथ.
CBC.
हाँ?
I don't know. I just spoke about CBC.
Cardiac enzymes.
And NT-proBNP.
CBC, you are right. See, NT-proBNP, because clearly if it is, I will not say ki it is must, because if you are, it's very clear with the X-ray and with the this thing, your findings. So you are expecting only NT-proBNP is going to be on the higher side.
True.
Right? So, but anyway, you can do it for sure. Okay? So cardiac enzymes also, because peripartum cardiomyopathy. So, but that could be MI also. You never know.
Yes.
Okay. Next. Interesting. Tell me.
Yeah, this is a chest X-ray and epi view showing some infiltrates in the hilar and perihilar region, emphysematous lung, and one intercostal drain at the anterior right side apex.
What else? Anything else you can see? दिख तो रहा है. Just try to say what it is. What are those white dots?
Yeah, I was also thinking, but I in the
There is right side ICD also.
something. Yeah, right side ICD you mentioned.
Yeah.
But
So, and there are more dots on the right side only. There are few in the lungs and few in the subcutaneous tissues. So I told you now, whatever you are seeing, at least mention that. In fact, कुछ भी नहीं समझ में आया तो these wires also you mention. ठीक है? Obviously these are ECG wires, but you mention that also. अगर कुछ नहीं समझ में आ रहा है. So definitely you are seeing these white dots are very obvious. Even if you are not able to find out what are these, just mention that.
Okay.
So can you make out what it is?
That cocaine balls
Mm.
or something, but they're not radioactive. I don't remember though. Oh, bullets.
It's not bullets, it's pellets, gunshot pellets. Yes. So it next slide.
54-year
डॉक्टर
old
हाँ,
man that
ये थोड़ा सा ना इमेज बहुत अच्छे से नहीं लिया हुआ है बट ट्राई टू फोकस ओके otherwise everything is visible you have to focus read it
A 54-year male diagnosed as a case of DCMP came to hospital with cardiogenic shock. Read the chest X-ray, identify the structures. What are the different types of mechanical cardiac support devices? This is a chest X-ray in AP view, showing lung shadows in both the sides along with the cardiac shadow, a bit enlarged cardiac shadow, blunting of the CP angle, right-sided central venous cath or HD cath in place along the internal jugular line. There's a tracheostomy tube in situ, and there is also a subclavian central catheter going on in the right side, and there is a IABP cannula coming from the lower end
okay
of the subclavian, and there are effusions showing with the blunting of CP angle.
okay what else
Post CABG status,
okay
but only one.
वो CABG नहीं बोलेंगे because you don't know whether it was CABG or
Yes,
it
yes,
was valve
yes,
वो sternotomy
yes, yes. Oh, हाँ, post
ठीक है
sternotomy
हाँ
status.
अभी मुझे और बताओ क्या है
But I am finding some crowding of the ribs. I don't know.
okay नहीं not much so can you see what
Device, there is a, yeah, yes.
means in the mediastinal region में कुछ ऐसे tubes kind of structures are there
Yes, 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 yes. Some mechanical heart, maybe.
what it is मतलब कितने
Mechanical
meter है?
circulatory
how
device.
many you
Heart mate kind of thing. Two tubes I can decipher
two tubes
coming out. Yeah, coming out from the mediastinal region.
हम ये थोड़ा zoom कर सकते हैं क्या ये picture Sudeshna can we zoom this picture
Is this a picture? हाँ.
हाँ now can you see that one is in the center one is on the right side
Yes, yes.
one is on the left side and one again a small part you can see coming from below like
Yes,
two
yes.
actually coming from
Yes,
below.
yes, yes.
One on the right
Yes.
side one on the left side
Yes, it's something mechanical circulatory device.
yeah
like
but can you
heart mate or
name it
tandem
Heartmate
or
and all,
heart mate.
these are commercial names na
Yes.
you have to tell that in medical terms what it is so this is IVAD
Mechanical
LVAD and RVAD so this right side both the tubes are RVAD के लिए left side both are for LVAD okay
it was a nice extra. Thank you, ma'am. I have never seen.
no so that's why I put that okay next next
A 58-year-old woman has presented to our LMO with pain in her abdomen and back. Please report the findings of the following CT scan. This is a CT scan image showing the mediastinal window, which is showing an aortic dissection both in the axial and the parietal section as well. Case of aortic dissection.
But which because you have to now tell me the types also classification so then be specific where all you can see the aortic dissection. Complete your answer.
Which level? Like,
Yeah, of course. In your this coronal section, you can see
yes,
it's
it's a type B kind of aortic dissection which covers the arc of aorta and the descending aorta as well.
you tell me what all are involved. It's clearly visible.
Like, ma'am, what parts of the aorta? The thoracic and
Like
abdominal
you
aorta.
have ascending aorta, arch of aorta, descending aorta, abdominal aorta,
Yes,
right?
the arc of aorta, descending aorta, and the thoracoabdominal aorta involvement.
And what about in this sagittal you're saying?
Hmm.
What about your downward extension?
The downward extension is as low up to the common iliac arteries also because the renal are until the common iliac and renal also.
Yes. So what about the any comment on renal? That's why I'm asking.
Renal, the right side, uh, there's cutoff of flow from the aorta, the right side renal artery. And the kidneys are also placed at a much lower level along with the liver.
That is okay, but
The,
it's in the
there's a
right
cutoff
side.
of flow
In the
in the
right
right
side,
side.
the
Yes,
renal,
ma'am.
yeah, brightness you can see, right?
Yes, yes, yes.
Is it there on the left side?
No, that
Can
much
you
brightness is
see
not there.
any hypodensity in the left side in the cortex?
Yes, yes, yes.
So which side it is getting compromised?
Oh, the left side,
Yes.
left side. Yes, because yes, 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 because the right side, the aorta is behind it, which
Yes.
I am not able to see.
Yes. Correct.
So there is yeah, left side decreased flow to the renal artery.
Yeah. Okay.
Yes, ma'am.
Next. Sorry. So what type of aortic dissection this is?
Type B,
DBK?
arc of aorta and descending involved. And type DBK is type 2.
You have to know it each and
Yes,
everything about aortic dissection from the critical care point of view, including the classification and including the ICU management. Okay.
yes, ma'am. Yes, ma'am.
Next slide.
This is an
Quite a
MRI of a
difficult one,
30.
but
Yes.
you can do that.
MRI of a 30-year-old patient who presented with sustained fitting and altered conscious state. Describe your findings. How would you confirm the diagnosis? How your management be? This is a MRI scan showing a hypodensity area at the left occipital zone and the some hypertensity area in the frontotemporal zone of left as well.
Yeah.
And I would like to see the clear DWIs as well and the contrast enhanced with contrast as well.
Correct. So I have not included the whole images purposefully to know that
Yes.
only how you are going to and how would you confirm. So what are you expecting? Patient is having seizures, altered sensorium, young male, young patient, and you said frontotemporal hyperintensity.
This can be infective cause, infiltrative cause, or it can be any like cerebrovascular accidents as well. And I would like to do one
But
EEG and see the other images.
EG and
EEG and the other images, the contrast images as well, CSF studies, if I am suspecting any infection, like
so
when
if you're
vitamin,
suspecting any infection, so what? CSF, yes. But that's what I'm telling you. What you are getting an idea with this image. Involvement of the frontotemporal region with seizure,
It
young
may be
patient.
herpes
Yes,
simplex maybe.
good. And what is the treatment of choice?
For any meningitis, unless confirmed over the microbiological, we
Yes.
normally started with uh, cephalosporin, the ceftriaxones, and along with vancomycin and acyclovir, and go ahead with the CSF and send the viral PCR and bacteriological confirmation.
Perfect. Yes. So,
And
along
along
with
with
that,
antiepileptics
yes,
as well.
yes. Don't forget for ABC also.
Yes, everything.
Okay. Yeah. Next slide. So
36.
this once again, this is containing 3 slides with the images. Okay. So see all the images carefully. Now read it.
A 36-year-old female has been recovering on the ward following intra-abdominal sepsis. She complains of worsening vision in both eyes before a level of consciousness falls and a medical emergency team alert is called. Soon after, she has a grand mal seizure. An MRI is performed. What does it show? What is the most likely diagnosis? Uh,
So you
this
saw
is the
this MRI?
Yes, yes, yes.
Next slide. You see this?
Yes, there are.
Okay. 1 second. Next slide. Okay.
Yes,
Now
there are
Now, again, if you want to go on
hyperintensity.
back previous slides, just let me know.
Okay. The MRI shows hyper intensity images in the both the occipital and temporal lobe, both the sides along with the frontotemporal extension in all FLAIR, DWI, and T1, T2, all of them. Likely, it may be a cause of hypertensive emergency followed by PRES or cerebrovascular accident.
Very good. So, why it is not ischemia or bleed? How you are going to distinguish with the ischemia? This can be infarct also, no?
Yeah, this can be infarct, but
This
PRES
is
is
an additional question to fetch you very good marks.
but this this temporo-occipital window is very common for the findings of the PRES.
That's
And
good. That's perfect
yes,
because that's one definitely with this we will immediately
yes.
we will say it is press. But in fact, can also be
In
possible
fact,
in
yes, but ma'am, in fact, there should be no much prominence of the sulci and the gyri.
we are seeing MRI, right?
Yes, yes.
So anything which differentiates infarct from this in press on MRI?
The associated gliosis with infarct.
No. Okay, I'll tell you in answer session. Next. That's very good. You answered. Very good.
An 85-year-old man has been bedridden for 3 days in a supported accommodation with pneumonia. The following electrolyte results have been obtained. Interpret the results. Sodium 171, potassium 3.8, chloride 134, bicarbonate 38, urea 35, creatinine 200, glucose 5, urine sodium less than 5, and osmolarity 94. There is hypernatremia, hyperchlorosis, hyperchloremia, hypernatremia. Urea is also high. This is maybe a case of cerebral salt wasting syndrome.
Creatinine.
Creatinine is 200.
So
And
what is coming in your mind? Tell me now. It's pneumonia and electrolytes are this thing. And what about the urine? Urine sodium?
This is one provisional diagnosis can be because of excess resuscitation with hyperchloremic saline, NaCl,
Okay.
leading to hypernatremia and hyperchloremia. At the same time,
But do you think that bicarb will be this high
Yes.
with 38?
maybe the
Because
background of actually the creatinine and bicarb are going in opposite direction. The creatinine is increased and is urea creatinine is showing some AKI kind of injury, likely AKI
so
or
what
acute.
kind of AKI injury you are expecting with this lab? Hypernatremia, hyperchloremia with metabolic alkalosis. And with sodium, urine sodium is very low. And osmolality, urine is trying to conserve water maximally by excreting absolutely concentrated urine. Na? It's
Yes.
924.
Yes, yes. It's like hypervolemic,
हाँ
hypervolemic hypernatremia.
हाइपरवोलेमिक हाइपरनेट्रीमिया. तो अगर हाइपरवोलीमिया अगर होएगा तो व्हाट अबाउट द यूरिन? व्हाट यू आर एक्सपेक्टिंग इन द यूरिन? Now you're seeing this urine biochemistry. Urine is trying to, urine sodium is less than 5, very low. So urine is trying to conserve
Trying to
sodium.
conserve the sodium. Yes.
Osmolality is almost maximal. 1200, 900, 1200 maximal rahega. So urine is trying to conserve water. That's why concentrated urine nikal raha hai.
Some CAD in the background of Legionella pneumonia. I don't know.
Legionella will cause hyponatremia, hypokalemia. Yeah.
I don't know. Not able to decipher.
If the patient is overly diurized, what will happen?
But there will be sodium will be so
क्या
much
होएगा?
increased.
Overly diurized होएगा. So
Yeah, the
can we expect
bicarbonate will increase definitely.
and creatinine will also ultimately start going up.
Up, true.
But then, but still, your kidney is trying to conserve water. And plus,
but the
if patient definitely, if patient has received on top of that soda bicarb or something,
that might be a reason.
right?
Yes.
Okay. So all these things in together you have to say.
Yes.
But मैंने बोला ना कि even if you are interpreting this, दोनों lab values, then also it's a very good because your serum you are saying and urine also you are able to interpret, na? It's
Yes,
very good. ठीक है?
yes, sir.
Next. I think that's the last. Okay. What is this?
This is the in TEG picture representation of TEG thromboelastogram. And it's showing increase arc time, increase maximum amplitude, increase angle. So it's likely hyperfibrinolysis.
Hyperfibrinolysis. And for hyperfibrinolysis, what you will see in TEG?
The maximum amplitude is increased.
Lysis 30 you will see, right?
Lysis 30. I recollect the tape poster.
So not read?
Read in the theory, but then I
so you have to read TEG also. You have to prepare questions on TEG. ठीक है? Most likely it will come. TEG or ROTEM. ठीक है? Because this is bedside or point of contact investigations, na?
Yes, ma'am.
And it will give you real time value. So that's why it's very important to interpret. ठीक है? Next.
The following biochemistry is taken from an IV drug user with severe cellulitis of an injection site. Explain the results. What underlying problems could cause this? There is hyperkalemia and
Hmm.
bicarb loss, uh, increased anion gap,
Hmm.
and hyperglycemia also.
Hmm.
High urea creatinine.
Very
I have
good.
to ask a provisional diagnosis.
Huh?
Myoglobinuria,
Hmm.
like, and also along with glycosuria, there is hyperglycemia as
So
well.
what it is?
And LFT is also raised.
Hmm. So what is the probable cause for this? IV drug use for severe.
Rhabdomyolysis.
Pardon?
Rhabdomyolysis.
Yes, of course.
Rhabdomyolysis.
It's
Yes.
severe cellulitis on injection site.
Mm-hmm.
So, but
Rhabdomyolysis.
can you tell me what could cause rhabdomyolysis in this patient? One is
What?
infection,
Infection.
ठीक है, but IV के साथ मतलब they are very pro for that. Other than that, what can lead to the severe cellulitis or rhabdo-like picture?
So, poor glycemic control.
Yeah, that's true. ठीक है, this is मतलब add-on I'm asking. This is intra-arterial, it may go and then might have caused all this problem.
Okay.
Okay, next. This is, I think, yeah, this is last. Okay. Stop sharing. I will try sharing the answers. So, Dr. Sudeshna, very good.
Yes, ma'am.
For sure. So, antibiotic carbapenem and gram-positive cover as per if suppose patient is admitted in the ICU, then as per your ICU, what organism is prevalent, whether it is CRE, CRO or MRSA, you have to give cover if patient is coming from the community. In these kind of patients, don't forget about CA, MRSA, okay? Because these patients are on steroids or immunocompromised state. So CA, MRSA cover will be needed along with other carbapenems or CRO cover also, if you think it is appropriate. If suppose this patient is coming and patient is hemodynamically very unstable, we always tend to use polymyxin group of antibiotics. If patient is very unstable, okay, polymyxin and targocid, okay. So is it right to use polymyxin and targocid, seeing this organisms responsible for infection in cystic fibrosis patients? Are you there, Dr. Sudeshna?
Ma'am, sorry, I didn't hear. Can you just repeat?
Yeah. So if suppose patient is coming and patient is very hemodynamically very unstable, so in that condition, you started, you thought that I will start with polymyxin group of antibiotics along with teicoplanin. Okay.
Yes.
So anything you will be worried of if you are starting polymyxin, because I have mentioned few organisms here. So my question is, what organism it will not cover?
It will not be covering the atypical Burkholderia cepacia and Pseudomonas as well, and the gram negative.
Burkholderia नहीं करेगा.
The Enterobacters it will not cover. And because polymyxin B monotherapy is not preferred in view
No,
of
definitely. You have to give that in combination. But if you are giving polymyxin, you have better to give it along with the carbapenem group, because Burkholderia will not be covered with polymyxin, right?
Yes, sir. But and Morganella Burkholderia atypicals are not covered.
Yes, yes, right.
Moraxella.
Moraxella, Morganella, Proteus, Providentia. These are not
Providence.
covered. Okay, this is, you rightly mentioned, peripartum cardiomyopathy. So there is cardiomegaly, bilateral hilar prominence, like more or less battling appearance kind of, blunting is there, and investigations, ECG, 2D echo, cardiac enzymes, and CBC also because patient is looking pale. So this one, just chest X-ray. This is ICD is there, and these small gunshot pellets are there. Okay. Along with that, slight emphysematous lung, heart, cardiac shadow is slightly elongated. So this one, dilated cardiomyopathy, cardiogenic shock. So this is the hint, okay, for this X-ray. And mechanical cardiac support devices. You didn't say what are different types of mechanical cardiac support devices, na?
No, ma'am.
Okay. Okay. So all lines you identified correctly. Can you see my arrow?
Yes, ma'am.
So one is this tube, one is this tube. Okay. These two tubes are going in the on the right side. Okay. For the
Yes.
RVAD. Okay. The other one is this tube. Okay. This one. And one is this one. This is for LVAD.
LVAD.
Okay.
Yes.
So this is BiVAD for heart mechanical cardiac support, and maybe patient 54-year-old male है ना, so maybe patient is a candidate for cardiac transplant. And other mechanical cardiac support devices, very commonly what we are using is IABP, intra-aortic
IABP.
pump, right? Then VA ECMO,
VA, no, LVAD,
LVAD
RVAD.
and RVAD, BiVAD, Impella,
Mechanical impella and mechanical heart, heart mate and all.
Yeah, that's what this VAD only.
VAD.
So this one again you have to mention कि this is the CT thorax, that is the mediastinal window, and that is showing this flap in the ascending aorta and descending aorta. Along with that, this coronal section, this is axial section, coronal section is showing your complete dissection in the abdominal aorta, also extending beyond the origin of the left renal artery, involving the left renal artery, and there are hypodensities. So this is the Becket type 1. You rightly said hypodensity in the frontotemporal, high signal in the frontotemporal region. So that is mostly infective etiology. Definitely you have to rule out with the other pictures also, and how most likely the site is for herpes simplex virus, HSV encephalitis. So confirmation of the diagnosis, you will do EEG, you will do lumbar puncture, CSF examination, and management, you rightly said, empirical, you will start with the antibiotics, ceftriaxone, vancomycin, and acyclovir. And later on, with as per the investigation, you will come down with that. But again, don't forget for anti-epileptics and ABC. So now this one. 36-year-old female, young female, worsening vision and seizures. So this is very classical for your press. So here, this is in this, it is looking more or less okay. But as you go down with the other MRI signals, then you are seeing T2 weighted. There is hyperintensity. There is hyperintensity here. And ADCO, you will see these hyperintensity. It is or press. In otherwise, in case of infarct, T2 weighted flare, you see image will get, so be able the two. Okay. ankle to 5.5 is chloremia. Higher creatinine, AKI is there. Urine osmolality is very high with very low urine sodium. So this could be the picture of volume contraction state along with some super added treatment with the soda bicarb causing such a high sodium, and bicarb high can be because of this volume contraction also and leading to AKI. So urine sodium is low due to increased sodium reabsorption in response to so hyperosmolar. So very high urine osmolality. It is because patient is maximally attempting to retain water in the face of his plasma hyperosmolality. So now this is TEG. Here you will see only your R time is high. Other than that, K is normal, angle is normal, MA is also slightly increased. Now R time is your factor functions. K time is fibrinogen. Your MA is platelets and lysis 30 is fibrinolysis. You have to remember these four things always. Okay? So if your R time is high and other than that, in fact, MA is high, means platelet function is very high. Okay? So, and lysis 30 is okay. So no hyperfibrinolysis, no hypofibrinogenemia. So here main issue is आपके coagulation factor के function का issue and platelet is over functioning. Okay. So this can be seen in case of if there is suppose patient is hypercoagulable. Along with that, patient is on some anticoagulant, which is acting on factors. Okay? So that will increase your R time. Or, but still patient is hypercoagulable. Or early phase of DIC, where there is, or early phase of HIT, जब thrombotic state. Okay? So platelet aggregation has increased. So that is also causing increased MA, but your because of this factor deficiency, your hypocoagulability has started. Okay, that also can be the possibility. So now this one, rightly mentioned, this is rhabdomyolysis picture, and severe cellulitis can cause rhabdomyolysis or intraarterial injection, which is causing gangrenous rhabdomyolysis. Or this can be a necrotizing fasciitis also. But you have to necrotizing fasciitis, no? There is, I think sodium is on the lower side in that condition. That scoring is there, no? For necrotizing fasciitis, skipped from my mind actually, but see that. So raised anion gap, metabolic acidosis, acute renal failure, high creatinine kinase, and hyperkalemia. With hyperphosphatemia, these all are associated with rhabdo. And so that's it. Renal failure, maybe due to dehydration, sepsis, hyperosmolality, and of course myoglobinuria that can cause pigment AKI nephropathy. Okay. So Sudeshna, what to do? Abhi, it's 7:47. You're done with 2 sets, no?
Yes. So,
Tell me.
what? Just I'll give you a call in a minute's time. So in the meantime, we can keep. So won't just be there. I'll just give you a call.
So listen now. What I'm saying, if they want to go with one case in between, can go ahead.
No, case is all done. Now today is only table viva.
Only table viva is left. ठीक है. So कैसे करें? I have to go for the duty. So next USG I'll do up abhi. Okay. So who is going to volunteer for that?
Ma'am. Yes, ma'am.
Okay. What happened?
So shall I read?
No, नहीं ये तो पुराना वाला ही आ गया, पता नहीं somehow it's
Okay. Okay. Sorry.
wait. Actually ना इसमें this is visible ना,
हाँ मैम.
but I am going to omit that one, this one, because somehow I'm not able to play the video here in this question.
Would you like us to present?
No. I saw yours only. In fact, I am only opening this one, which you had sent, na. So,
Hmm.
but I am not able to open the video. I think video is not playing in this particular. Otherwise, in all other questions, na, it is there.
Yeah. So, will I present in this case?
Uh,
Will I share?
yeah. You share.
Okay. Just one.
There
Let's
is.
just stop sharing. We are
Yes. What happened?
That is not a video. That's a picture only.
No. Actually, that video. Yeah. Ashwini, go on.
Yes ma'am. So question is, what does this represent for LV function?
Hmm.
Mm,
What is this?
Okay, so this is representative of the diastolic dysfunction,
Hmm.
and the grade of diastolic dysfunction is, I think,
To calculate, but ठीक है, diastolic dysfunction. Next.
yes.
वीडियो है क्या इसमें? Yes. Video is there? नहीं? Okay. ठीक है. What is this?
So this is a USG lung.
Hmm.
Again, I can see the starry sky appearance suggestive of shred sign, maybe consolidation.
Yes. और इसका वीडियो क्यों नहीं आ रहा है? Okay. Next. Here video is there.
Okay, so this is the
वीडियो
young
प्ले
woman.
करेंगे? है यार. हाँ. Tell me what it
Okay.
is.
So this is the this young woman presented with 2 days of shortness of breath and right-sided chest discomfort after a long haul flight. So what does this demonstrate? Can you play video again, ma'am? This is a USG of diaphragm.
Tell me what it is.
This is a this curtain sign of diaphragm movement.
What else? So she's having right side chest discomfort and scan was done. So obviously only to see only the diaphragm we are not going to do now.
Yes, ma'am. This air collection is there.
Next. Ashwini. Next question.
Okay. So this is thin and tall young man presented with back pain. Okay, dissection of aorta.
Yes. Next. Next question. Play the video.
Okay, this is the right diastolic collapse plus pericardial effusion is there. Collapse is there, cardiac tamponade.
Okay. So what you are going to do?
So I'll go for pericardiocentesis.
ABC.
I'll find out the underlying cause of it, and
Hmm.
then I'll go for the pericardiocentesis.
So definitely pericardiocentesis, because that will give you idea about the underlying cause of it, right?
Underlying
But
cause, yes.
definitely you have to don't forget to mention airway breathing circulation, because
Yes,
this kind of cardiac tamponade
is a medical emergency.
Yes.
Yes.
Next.
This is the optic now sheet diameter.
Very good.
So the diameter is which we
Don't
are
tell me-
doing for.
Don't tell me the values, because obviously you will not be able to calculate. Medical significance bedside.
So medical significance, this we are calculating to find out whether raised ICP is there or not.
Yes. So this is non-invasive
Non-invasive method of calculation of raised ICP.
bedside.
Bedside, yes.
Okay, that's important. Ashwini, can you please go ahead with the ACLS also, if okay for you?
Yes, ma'am.
Or anyone else want to go with the ACLS? Anyone else will volunteer? Okay, let's go. Next slide. I'll answer all the questions simultaneously. What is this?
Okay, this is the CVP line. X line.
What is it showing?
X is X descent is that it's I forgot name this is CVP.
Okay. Next. What is this?
So this is the hemodynamic monitor, hemodynamic monitoring. So the cardiac index is 2.2, which is normal. This SVV is 80%. SVI, systemic vascular index is 31. SVRI is 1595. I think they are within normal.
So what is this monitoring?
This hemodynamic cardiac monitoring.
Yeah, but in what type of cardiac hemodynamic monitoring? You are getting all these values, na? Nahin?
No, ma'am.
Okay, next. And interpretation, can you make out with the values?
Yes, but cardiac output, cardiac index was normal. It was not cardiogenic. Yeah.
Ashwini, IABP, please don't make any mistake
Yes,
here.
ma'am, but then
It should inflate at the dicrotic notch, na? Is inflating after dicrotic notch.
Hmm.
So it is late inflation.
late inflation. Yes.
Next. You should know the consequences of it, right?
Yes, late inflation will cause the decreased cardiac output
Q.
because it is inflating late. Now that's why it is obstructing the cardiac output and heart won't pump properly.
What is this?
Identify the waveform and comment on its accuracy. Arterial, this is indicative of the arterial line in C2. So,
Comment on the highlighted part and the line tracing. Yeah, we had already covered this day before yesterday's. नहीं, ये भी.
this is
What about the BP? 338 by 143.
yeah, it's very high BP. And
what about the tracing? Narrow area or wide area?
it's narrow.
किसमें
Very narrow.
मिलेगा? Next.
Okay, this is 75-year-old male patient, known case of COPD, presents with increased sputum production, palpitation. Interpret the ECG and the reason for the diagnosis. Okay, this is COPD, and I can see the multiple morphology of the P wave. So this is multi-atrial tachycardia. Hello.
Sorry, हाँ अश्विनी बोलो.
So this patient, so I can see in ECG there are more than 3 morphology of the V wave, which is suggestive of multi-atrial tachycardia.
Multifocal.
Multifocal tachycardia. Multifocal atrial tachycardia.
Yes. And reason?
Reason because he is underlying COPD, so cor pulmonale will be already there. Right heart failure will be already there. So right atrial hypertrophy. Right atrial, right ventricular hypertrophy will cause this.
Okay. And along with that?
Re-entry of
Recording in progress.
Okay.
Recording stopped.
Ma'am, I can see your screen. I am here.
Wait. I think that was. Wait. You can see my screen, right?
Yes, now I can see your screen.
Okay. Right. So what is this?
Okay, this now. So this is a 55-year-old male patient presented with ER with dizziness, fatigue, heart rate of 35, blood pressure 80/50, and the patient appears pale and diaphoretic. So there is no association between PQRS. This is complete heart block.
Good. What is this?
So 70-year-old male patient present with chest pain, dyspnea, dizziness, blood pressure 90/50, saturation 83 on room air. So I can see the T wave inversion, hyperdynamic T wave inversion V1, V2, V3, suggestive of anterior wall MI, valence sign, proximal LED, critical proximal LED involvement.
Say again.
Proximal LED involvement, valence sign.
Valence sign may you will get biphasic T wave, right?
T wave inversion, hyperdynamic T wave inversion also. Anyways, this is anterior wall MI.
Okay. Anything else you can think of?
I can not really.
Okay. Next.
So 30-year-old male patient presenting with generalized weakness. So STT changes are hypokalemia. So ECG changes are suggestive of.
Recording in progress.
You have to mention ECG changes, na?
So U waves are there, suggestive of hypokalemia.
QT prolongation, U waves are there. Biphasic T wave is there. What is this?
This is 45-year-old female patient with history of recent surgery, suddenly collapsed on the road. On arrival to EMS, she found unresponsive, pulseless, apnea. CPR is started and ECG shows the following. Okay, this ECG, okay. Okay, she is unresponsive and pulseless. Okay, and ECG is following. This is pulseless electrical activity. Pulseless, right? Huh. So, and 2D echo.
नीचे दिख रहा है ना?
हाँ, this is 2D को heart is contract.
What about this, and this? See each chambers and try to
Yes.
answer.
So I can see the right ventricle is right ventricle is dilated here. So is this pulmonary embolism?
Yes. मतलब मेरे को क्वेश्चन पूछ रहे हो?
No, ma'am, I'm answering it is pulmonary embolism because initial rhythm is also pulseless electrical activity commonly seen in pulmonary embolism.
Yes, and there is dilated RV.
Dilated RV.
It has become D-shaped septum.
In first echo picture, we can clearly see dilated.
This is your RV, right? So here you will be able to see more of your RV pre-wall dysfunction.
Yes.
Here you will be able to compare better between the LV and RV. And here looking like dilated IVC.
But collapsing
is there because the patient must be getting ventilated now. So it depends about, but obviously this is not the sign which will rule out.
Yes.
What is this?
Okay, this is 32-year-old pregnant female suddenly collapsed in hospital waiting area. She is unresponsive, apneic, pulseless, bradycardia. Just wait a second, ma'am. My door is ringing.
Recording stopped.
Hello. Ma'am. So, 32-year-old
Recording in progress.
female patient suddenly collapsed in hospital in waiting area. She is unresponsive, apneic, pulseless. Bystander call for help and the code team arrive. ECG shows the following finding. What you will do? Okay, this is she is pulseless, right? Okay, she is in cardiac arrest, code team arrived and ECG. So this is a ventricular tachycardia, pulseless ventricular tachycardia. Immediately will give shock.
Is it like only ventricular tachycardia you are going to mention, or you are going to use any adjective for that?
Polymorphic ventricular tachycardia, torsitis depointis.
So what are you?
Means magnesium. Main treatment will be means shock anyways and magnesium.
Okay. So unresponsive, apneic and pulseless, na? So you have to follow CPR protocol and defibrillation.
Yes, shock. Anyways, my priority will be defibrillation.
Yeah. So this was the last, I think. Yeah. I'll start sharing the
Ritika,
answer.
Dr. Ritika,
Yeah,
Dr.
tell
Ritika,
me now.
drugs and instrument can be done by Dr. Kedia. If you can manage, then it's great.
No,
If
no,
not, at least
yeah,
take the debriefing of the last
yes,
two.
yes. I'll do that only. Okay. And I'll request Dr. Kedia to do that, please.
Yes.
And my screen is visible?
Yes, ma'am.
Okay.
Can you
I
please
think
put it
ये
to full
somehow
screen?
this was missed. I think आपके पास भी नहीं था Sudeshna. I'll just play this. Ashwini, tell me what is this?
47-year-old man fall from height onto wall, hitting his left chest wall. He's complaining of chest pain, and his USG is. Can you play Can you play it again? So,
Sorry.
pneumothorax. I have seen once. When it is looking like diaphragm only,
sliding is
ma'am.
absent.
Yeah, okay, it's okay.
Mention भी है फिर lung USG. ठीक है.
न्यूमोथोरैक्स का कुछ साइन नहीं है. ओके मैम, चलेगा.
Lung sliding नहीं है ना? See?
अच्छा, lung sliding is absent. Okay.
It's moving as a whole. So ये भी शायद नहीं play हुआ ना. So this was actually acute cholecystitis with GV neck stone.
Okay.
So this you mentioned rightly. This is because I have given in the question. This is the LV function to represent the LV function. So that is your mentioning LV diastolic dysfunction. This is pulse wave. Okay.
Okay.
And for LV diastolic dysfunction, you should know the grading of LV diastolic dysfunction.
Yes.
इसमें नहीं था ना कुछ भी नहीं. So yeah, rightly mentioned, rightly answered. Left lung. So left lung. These are hepatization, you can say, and suggestive of pneumonia. This is the diaphragm, lung shred sign. So this one, Ashwini, where is the air collection you will see? You will not be able to see air collection, right? You will be able to see any lung sliding is absent, or your ये barcode sign is there. ये है ना? This is your diaphragm.
This is diaphragm.
So this is collection, na?
Okay.
This is some collection, and you see there is no lung movement. So it is most likely because of a long haul flight. Either it can be some trauma or spontaneous rupture related pneumothorax.
Okay.
Okay.
Yes.
This one rightly mentioned. This is abdominal backache tha, USG abdomen kiya, the abdominal aorta with flap. This is liver. So this is suggestive of dissection, aortic dissection again. This is mentioned. So here again, why this is not pleural effusion? Why this is pericardial effusion? Why?
Pericardial effusion because ma'am, right, this ventricular collapse is this was
मतलब how you are going to identify, na?
No, fluid collection is there on the lower side, so on that
this is your descending aorta. ठीक है? See my arrow?
Yes, ma'am.
So this is your descending aorta. छोटा सा जो दिख रहा है इधर या फिर इधर, right? So if the collection is above your descending aorta, that is your pericardial collection. If you are seeing any collection below this descending aorta, that is your pleural collection.
Yes.
So this is optic nerve sheath diameter, rightly answered. So A, C, B, Y इतना छोटा है and sharp X descent. This is suggestive of
pericarditis.
Tamponade.
Pericardial tamponade.
Because Y descent नहीं हो रहा ना. This is the dilatation.
Sharp X descent. Yes.
हाँ, अच्छा चलो. So this is your I'll go a little fast. This is your volume view for advanced hemodynamic monitoring. And here you are seeing cardiac index is little low. In principle is your thermodilution technique, right? So this is transpulmonary thermodilution technique. we all, a lot of informations we get from here, like extra lung water index, PVPI, and GEDI, then cardiac index, SVV, SVI, SVRI. So this helps in your hemodynamics wise, like patient is fluid responsive or not, cardiac wise, patient is in cardiogenic shock. And second is, it will also distinguish in case of ARDS whether patient is having cardiogenic pulmonary edema or non-cardiogenic pulmonary edema by seeing the values of ELWI and PVPI. Okay. So details, obviously you will get anywhere, but this is very important significance of this, that you will be able to identify in ARDS patients also whether we should give fluid to patient or not. So this is, see, IABP tracing. This is your dicrotic notch. Usually at dicrotic notch, it should inflate. And the highest pressure is your augmented pressure. Here you are seeing it is inflating after dicrotic notch. So definitely it is delayed inflation, and this is not augmenting also, because this augmented BP is less than your unassisted, right?
Yes.
So it is early inflation. You have to, it is delayed inflation. You have to adjust with early inflating it little before. This is under dam. What was the problem?
Okay, yeah.
This is Matt, correctly said. Yeah, your causes also you mentioned, RV, H, and cor pulmonale will cause that. Multifocal atrial tachycardia. So here, CHB you mentioned, complete AV dissociation is there with bradycardia and hypotension. This is this chest pain, dyspnea, dizziness, BP 90/50, saturation 83% on room air. So Whelan sign will be your biphasic T wave, matlab, and first one will be positive and second one will be negative. Here you are not seeing the positive T, right?
Okay, ma'am.
Okay, this is S1, Q3, T3. Very classical. Pulmonary embolism. Though it's not always suggestive of pulmonary embolism, but in case of this background clinical picture. This is hypokalemia, rightly mentioned. This one, pulmonary embolism as the cause of cardiac arrest. This is polymorphic ventricular tachycardia. Okay. And this is not VF, right?
No, ma'am. This
Because
is not
VF ka rate will be too high. So this is polymorphic ventricular tachycardia, CPR, and defibrillation. Okay. Okay.
Yes.
Can I leave? Thank you so much. And keep on preparing, keep on practicing.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you.
Thank you. So I'm leaving.
Ma'am, you can leave. I have seen your slides. I
Yeah.
will try to justify with these 10 questions. And
Thank you
as
so
you have
much.
made, but I will try to
Oh,
give
yes,
as
yes, you will absolutely will be able to do that. It's
Okay,
nothing
madam.
very.
You can leave. You can
Yeah.
leave, ma'am.
Thank you so much.
Thank you.
So who will be the next volunteer? Anybody please type your name in the chat box. Dr. Gulkiran, excellent.
Dr.
Yes, ma'am.
Doctor, who will take?
Yes, sir.
Gulkiran.
Good evening.
Are you ready?
Yes, sir.
And you have taken a lot of cases, lot of discussion from the starting. And I have seen that your answers are also like very good and your preparation is good, but continue this effort. Okay.
Yes, sir.
So there are last few slides as madam has to leave because of some important issues. And these slides were made by madam, but okay, there are very important questions that can be asked. So I will go with the questions and along with the answers together because he has prepared, so it will be easy for us. Okay.
जी सर.
So now this is the first drug in the drug and instrument, and can you just see
Sir,
this?
this is a glycopeptide teicoplanin.
Yes.
Group of antibiotic. It is used for methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococci.
Very good.
This is
Very
1
good.
gram. This is 200 milligram vial. The dose is 600 milligram BD for 5 days, followed by 400 milligram once daily.
So one thing I will suggest you, whenever you are saying any dose, so don't say any fixed dose. Okay, try to say in this per kg body weight. So whatever
Okay, sir.
you have said is a good for any adult patient or what you are thinking 60 to 70 kg patient, but in other cases, try to say in a per kg body weight. So the answers, like I will debrief continuously with the questions. It is a glycopeptide antibiotic, you have said rightly, and the indication you have said also rightly, but dose wise, if you will say, and the first 3 doses are given in the 12-hour interval, and then it is an OD dose. So it's not a busy, like it is 6 milligram per kg body weight, and it is 12 hourly first 3 dose and then 6 ml, 6 milligram per kg OD dose. Okay. Now coming to the next question, sir.
Sir, this is a prothrombin concentrate complex. This has got factor 2, 7, 9, 10, protein C and S.
Okay.
This is used for patients who are on vitamin K antagonist or patients with liver dysfunction.
Okay.
And in massive transfusion, it has role, massive transfusion protocol for hemostatic resuscitation.
Very good. Very good. You have seen the answers or not?
No, sir.
Think what you have told. Okay. So it is a really prothrombin concentrate complex. They will ask this composition of this and indications. So major indication are a massive bleeding with factor deficiency, and as you said rightly, in a warfarin reversal. Okay.
Yes,
so
sir.
going to the next, this one.
Sir, this is a N-acetylcysteine.
Very good.
This is used for patients with acute liver failure, wherever there is loss of body's oxidative capacity, and we have to do metabolic resuscitation with antioxidant, where there is the dose is the usual dose is 160, 50, and then 100. 160 milligram. Sorry.
You are saying for
9
acute
gram,
liver
5
failure.
gram, 9 gram, 3 gram, 6 gram.
You are saying acute liver failure, right?